Tell me a little bit about this abstract concerning AI imaging of kidneys prior to partial nephrectomy. How did this idea come about? And tell me a little bit about just what you're looking at.
Yeah, so first off, thank you so much for having me. It's great to reconnect. The abstract came about, I think, from a sort of as part of a broader effort that we've had in our department for a few years now, which is trying to develop sort of an automated analysis platform for kidney cancer imaging. So specifically, using AI and automated image segmentation for kidney tumors and as distinct entities from benign parenchyma. The thought behind this particular abstract was that, we know from lots of retrospective literature across various centers that the amount of normal parenchyma that we save at the time of partial nephrectomy is probably one of the most important factors in terms of long-term kidney function. But operationalizing that into practice is sometimes hard, right? Like we can't be in clinic and sit and measure the amount of kidney function. And so for this particular project, we said, well, is there a way to leverage the automated segmentation tool that we've already created and apply it to this particular use case?
It's super helpful, super interesting. There's been so many times I've been in clinic trying to tell a patient of what the likelihood of them being on dialysis after their surgery and looking at the other kidney and saying, I think that one's going to be okay. How do your findings make that a better informed conversation for shared decision-making with your patients?
That's a great question, and I think really insightful. So, kidney function after extirpative kidney surgery, as you know, is really complex and it's multifactorial. And at the end of the day, baseline or preoperative kidney function is always going to be the biggest driver of that. But the ability to now incorporate some of the actual sort of volumetric data, I think just adds to that equation. So historically, we've looked at, generally when we're in clinic, we'll kind of say, okay, this is the baseline creatinine, and we'll kind of eyeball the volumes of the kidneys sort of subconsciously. And I think this helps us really quantify that and bring it into a practice in a way that's actually maybe a little bit more robust than what we've done sort of informally.
So perhaps not surprisingly, you guys found that contralateral kidney volume matters. The more of it you have, the better. How does that, how can we use your AI technology, say at the Mayo Clinic, you guys have this is great, but how do we implement that to other people? Is it hard? Or is it easy to get that out there and get people access to this? Is this another thing that's going to create socioeconomic disparities for people that may not have that technology or the ability to access that technology?
Yeah, those are honestly really good questions. I think the sort of next phase or looking forward is how do we, to your point, how do we translate this sort of very academic exercise into practice? And that's something, ideally, eventually this type of technology would be available broadly, but we're starting with just our hospital. And we're actually this quarter rolling out part of our segmentation algorithm into the practice. And so, when we see a patient in clinic and we're counseling them, we'll not only have kind of data available about their baseline kidney function and their tumor characteristics and all the things that we usually look at when we're thinking about shared decision-making, but we'll have maybe a little bit more objective, concrete data in terms of split volume. We're looking at exploring split function as well. And so, I think this is sort of baby steps, right? We'll start by developing the technology, refining it, implementing it sort of locally, and then, we'll see after that.
Yeah, that's super interesting. Would be super helpful and actually brings down the amount of resources you need for any given patient, because you just mentioned 3 different things that probably require 3 different studies to figure out that now you've condensed down into one image that they're getting anyway for their kidney cancer. So that's super interesting. Where do you see AI going in the future as far as kidney masses, maybe even surveillance of kidney masses or decision-making in surgical management of these masses?
Yeah, it's a great question. I think there's quite a bit of work yet to be done, and our group and others have been working on this for some time. And I think some of these are hard problems to crack. So things like, trying to predict tumor behavior, tumor histology, long-term sort of outcomes from an oncologic standpoint, trying to predict, perioperative outcomes. So these are all things that we've historically done using clinical variables. And I think those clinical tools or nephrometry scores and all that stuff will never really go away. But the question we're trying to answer is it potentially doable to add a little bit of more, imaging-based data to the mix? So not to stand alone by itself, but in addition to all the clinical tools we already use.
So I'll get you out on this question. There was a very famous paper from the Mayo Clinic that said every second counts with clamp time. You looked at preoperative volume in renal, in kidneys. Does every milliliter count? And what happens in the operating room obviously has an impact on your outcomes that did you or did you not account for in your work?
Yeah, so it's funny you referenced that. Obviously, a historic paper, multi-center data, and I think what's interesting is, time, ischemia time obviously is a factor, and I think more and more we've realized over the years that probably preserved parenchymal volume matters as much, if not more. And we're not necessarily showing that. That's, I think, already been shown and well accepted. All we're really hoping to do is figure out how to operationalize that and sort of quantify it in an objective way.